Good morning, everyone. Myself, Dr. Chandrakanta from KGMU Lucknow. And on behalf of DGME, DGHS, and Department of Pediatrics, I welcome all of you to this 4-day long training program. And other than Department of Pediatrics, KGMU, a lot of other medical colleges has also contributed in this training program. And these colleges are SGPGI Lucknow, RML Institute Lucknow, BHU Varanasi, and AIMS Rai Bareilly and SRMS Bareilly. So faculty from all these medical colleges were involved in making modules for this training program, and I am will be benefited training program. As we have seen during second wave of COVID, that a few percentage of children were also suffered from COVID or other complications of COVID like MISC. So this is in preparedness for the third wave if it happens, though nobody wants that the third wave should happen in India. But it's better to be prepared. So I'm hopeful that after this training, you will be more knowledgeable about the management of COVID-19 in children. So in this training program on day 1, we will discuss mainly the different clinical presentation, mild, moderate, and severe COVID. And the day 2 program is mainly focused on oxygen therapy and non-invasive ventilation. Day 3 program is mainly focused on invasive mechanical ventilation in children, how to do it in COVID. And fourth day, we will discuss some other important topics. So in this training program, there will be a pre-test in the beginning, and at the end of the training, there will be post-test, and you have to do pre-test and post-test both, and you have to attend all the sessions for 4 days. Then only you will get your certificate. So before we start the pre-test, Mr. Neeraj will brief you about the pre-test, and pre-test will start at 12:10 and the time will be for 20 minutes. At 12:30, we will start our session. So Mr. Neeraj, please brief the participants about the pre-test.
Hello, good morning, everyone. We'll go through the message what you have received on your email and on your mobile, basically on WhatsApp. That message contains basically 3 links. The first link is of Zoom. Using this, you can connect the training via Zoom. The second link is YouTube link. If you are facing any issue, there's a network problem, you can also use this second link to connect to the training. And the third one is your pre-test link. You have to click on that link once we activate it. If you have already clicked on the link on this link before, so you can see a page that the Google form is not accepting the responses. If you have already clicked, you have to click on this link again as your name, your mobile number, participant ID, and your email ID will be pre-filled once you click on this link. If you are not unable to see these links on blue color, I request you all to please save this mobile number from which you are getting WhatsApp. And also, I'm also just want to explain how this message looks in your WhatsApp. You can see this was basically incomplete message. You are unable to see this second and third link in this WhatsApp. So you have to click on this read more. When you click on this read more, you can see the complete message and the link is at the bottom. And when you click on this link, the pre-test form will be opened. If any of you is facing any issue in giving the pre-test, you can WhatsApp on the number from which you are receiving these links. Request you to please avoid calls, as I am here to support all of you, maximum of you. So it's little difficult if you will call. So I'm activating the link, and I'll inform you when you have to click. Link is activated. You all can opt for the pre-test by clicking on the link what you have received on your email or in WhatsApp. If you are facing any issue, you can message me on that WhatsApp number.
नहीं अभी प्री टेस्ट चल रहा है ना शायद इसलिए मैं अपना स्क्रीन शेयर कर हाँ शेयर क्या है स्लाइड अभी नहीं अभी उनका टेस्ट और नहीं
If you are not getting your participant ID, means you have all clicked on that link before it's get activated. So I request you to please go to that message again, and you have to click on that link after it's get activated. Means you can click it now, and you'll get your participant ID, mobile number, and all general details pre-filled. Those who are facing issue with the participant ID, I think they can fill their name in place of participant ID.
बता तो रहे थे ये लोग क्या जाएंगे, चेयरमैन सर और आदित्य सर दोनों
अजय सर तो नहीं आएंगे,
नहीं आएंगे।
अजय सर आदित्य चार्ट में सर हो सकता है
क्या आदित्य सर? सर आपका कैसा रहा वो एग्जाम, कैसे थे बच्चे?
ठीक ही, एक बच्चा कमजोर था, अदरवाइज प्रेजेंटेशन वगैरह अच्छे थे।
बस मैं अपनी निकाल
एक फाइव क्या क्या
सर प्रिंट आउट निकालना है, निकल गया प्रिंट आप निकल बैठे ना सर। मैम इज इन एनाटॉमी डिपार्टमेंट।
बैठे बैठे
भैया देखो नहीं चल रहा प्रिंट आउट पूरी अरेंज कर
इसमें लगा तो नहीं जस्ट साइन व्हाट्सएप वेब का व्हाट्सएप वेब ये इसी बेसिस पे करना दूसरे। हाँ व्हाट्सएप वेब हाँ आइए। क्या क्यों मेरे साइन क्यों चाहिए?
सर बिट्टू मैम ने कहा है और नीचे भी कहा है कि आपके साइन होंगे, आपके यहाँ
आप इसका ये दिखाइए ना मुझे, ये तो मेडिकल फिटनेस है, मेडिकल सर्टिफिकेट कहाँ है? आप पेपर दिखाइए मुझे।
All the participants must have submitted the pre-test, I think. Those who have joined late, please submit it quickly. Mr. Neeraj, I think pre-test link is closed now.
Yes, ma'am.
Okay, so all of you, please submit your pre-test quickly. So today the first talk will be taken by Dr. Vedika Bhatt. She is from RMC Bareilly and she will be talking about the COVID-19 infection in children. So welcome Dr. Vedika.
Actually, ma'am, something has happened with my laptop. It was showing the screen and suddenly it has crashed. It will take me 2 minutes. I'll just log in and...
No issue, no issue.
Yes. Yeah. चलेगा ना? I hope my slides are visible, ma'am.
Yes, Dr. Vedika. And your voice is also clear. So please start.
Ma'am, my voice is audible.
Yes, yes.
Are my slides visible, ma'am?
Yes, yes. Your slide is visible and your voice is audible.
Ma'am, I'm not able to hear your voice, ma'am.
Hello, Vedika. Please start.
Ma'am, my voice is audible, ma'am?
Yes, yes, Vedika. Your voice is audible.
Yes, ma'am. Thank you. So, good afternoon, everybody. My topic for today is COVID-19 infection in children. As we all are aware that we are anticipating a third wave. We don't know when and when it is going to be there. But yeah, definitely there was a prediction that it would affect children in a larger numbers and so much. So are the apprehensions. So we exactly don't know. But then it is better to be prepared for the worst and hope for the best. So let's get ourselves well versed with the topic of COVID-19 infection in children. Sessions for today will be talking about each and every aspect of COVID-19 infections in children in detail. I'm just going to present an overview regarding this situation. As we all know, there was a first wave and the second wave began from Jan 2020 and it's still going on. So this is data which shows that global cases at the end of May 2021 were somewhere around 1.58 billion with a total deaths of 33 lakhs, whereas the situation in India, the total cases reported were approximately 22 million with the deaths of about 2,45,000. And this data is up to the end of May. We are aware that there are various variants which are coming in, the Delta plus, the Delta plus plus variants, and the cases are being reported. So now coming to COVID-19 in children's status. So in the first wave and in the second wave, the children less than 20 years, the proportion of children who were affected below 20 years were constant. So that was around less than 12%. Though the total number of children that were affected in the second wave was larger than the first wave, however, the proportion remained unaffected and it was less than 12%. And the deaths were accounting to about 3%. Now, the first wave, as we had seen, were affecting more of the elderly and the people with comorbidities. And then we saw the second wave, which affected largely a population around 30 to 45 years. And now, as we are anticipating a third wave, we are of an apprehension that that particular wave may affect the lesser age group, that is below 30 years. And then children could also be a part of it because they are the ones which are unimmunized right now. So why there could be a resurge? So why is there going to be a resurge? We all know that lowering of the guard would be an important contributing factor. As we are all seeing, people around us have already stopped using masks. As we go to the market, people have stopped using masks, have stopped following social COVID appropriate behaviors, etc. So definitely, if this would be the scenario, then we could anticipate a third wave sooner or later. So lowering of the guard is an important factor. Then state of unlock. So state of unlock is something which is we cannot avoid, but then we should at least practice that as much as possible. We maintain a state of lockdown. So we should not be going to markets unnecessarily, right? And avoid social gatherings or social public meetings, etc., as much as possible, so as to maintain social distancing. So a state of unlock could be one factor for research. Mass gatherings, obviously, again, when there are mass gatherings and people are not following the COVID appropriate behavior, that is wearing of mask, etc., then there could be a resurge. Then lack of adherence, that is distancing and mask use, as I already told you, and mutant strains. So these RNA viruses are known to have mutations. So they have replication errors. So when they are replicating, they are known to have errors, and because of the error in replication, they are known to have mutant strains. And these mutant strains can cause infections, a wave of infections, like the first wave and the second wave and the third wave. So these can occur in waves, and they are inherent property of these RNA viruses, so that is not avoidable. But definitely the above points, that is lowering of the guard and avoiding mass gatherings, etc., are something which we can avoid, right? Now, what are the do's and don'ts? As we all are aware, so the do's include hand washing and hand hygiene practices, following cough hygiene practices, whatever disposables or tissues you are using to wipe your nose, etc., has to be disposed in a closed bin. Then seek medical professional help or helpline whenever you have symptoms pertaining to COVID, or if you have come in contact with a person of COVID infection. Then avoid mass gatherings or social gatherings has to be avoided as much as possible. What are the don'ts? So if you have any COVID-like symptoms like a LRI or a URI type of a symptom, then you should avoid contact with other people, avoid repeatedly touching your nose, etc., and then avoid spitting in public places. So these are the don'ts. Now, why are children going to be more prone in this surge? As I already told you, the absolute numbers have increased, but the proportion has remained the same, that is less than 12%. Now, we all know that the adult population are being vaccinated, and it is the majority of the chunk is the children who are unvaccinated right now. So that could be an important reason. However, recent sero surveys in places published that the seroconversion rate of children between 10 to 17 years was somewhere around 25%, and it was comparable to adults. So we think that the children were also affected in the first wave and the second wave, but majority of them remained asymptomatic, and that's why they were not detected. And then important complication of COVID in children is MISC. This is unique to children. So this is one thing which we are going to see in the children after an interval of 2 to 6 weeks, or sometimes it can occur even with the active COVID infection. So this is a peculiar complication which is going to be seen in children per se. But however, luckily, secondary infection rate are quite low in children, and there are less chances of severe COVID in children. Now, what are the effects of COVID-19 in children? So we have the direct effects and the indirect effects. So the direct effects are similar to that of adults. They could have an acute respiratory infection, a URI or a LRI. GI symptoms. GI symptoms could be the predominant presentation of COVID-19 in children. Unlike in adults where the respiratory symptoms were more prominent, children could present mainly with diarrhea, pain, abdomen without any respiratory symptoms, right? Then MISC, which is going to be discussed in detail in the coming sessions, is a very unique complication in children and adolescents, and it has a temporal relationship with COVID-19. Then there are certain atypical presentations like the dermatological manifestations. Now coming to the indirect effects, we all know what are the indirect effects of COVID in children. We all have toddlers at home and children at home, and the schools have been shut down. So they are restricted to be in the house. And that has definitely affected their mental state. Their screen time has increased. There has caused mental health issues, learning problems, because online classes are going on, which is itself a big difficulty for the parents. Then ability of the parents to work, yeah, definitely, because the children are at home and children are at home and you cannot leave them alone. So it has caused difficulty to the parents to go to work. Then there was some downscaling of regular child and maternal health preventive services, but as far as possible, they have tried to recover it. And then the nutritional status, obviously, if there is a lockdown, and that is going to affect the economy of the house, so per capita income is going to decrease, so that will indirectly affect the nutritional status of the children also. So they were the indirect effects of COVID-19. Now coming to the modes of transmission, we are all aware of the modes of transmission. So you have the respiratory mode, that is a respiratory virus. So it is mainly transmitted by the contact transmission, the droplet transmission, and the airborne transmission. So droplet transmission, here the large and small respiratory droplets which contain the virus, which could occur near to an infected person, whereas airborne transmission, the distance is longer. So the suspended viral particles are traversing over a longer distances and causing infection. So initially the excessive emphasis was on contact transmission, but however, droplet transmission and airborne transmission are also equally important. Diagnosis, we are all aware. So you have the PCR, that is the RT-PCR, and the CBNAT. So they remain the gold standard. The RT-PCR still remains the gold standard test for detection of COVID. Then you have the CRISPR technology and the loop-mediated isothermal amplification. These are gene editing techniques which give a results at a faster rate. They are being utilized for cancer therapies and sickle cell anemia therapies, and they are being investigated for use in COVID-19 also. But the operational validation is still awaited. So you have the antigen detection, the antibody detection. So the antigen detection is the point of care test, whereas the antibody detection is not useful for acute disease. However, the serology is important in diagnosing patients with MISC. Then what are the samples which are going to be taken? So you know that it is the nasopharyngeal or the oropharyngeal swab, which remains the gold standard. The other samples which can be utilized are bronchoalveolar lavage sample, the sputum sample, and certain studies have shown that even saliva can also be used as a sample. However, it is not still validated. Now coming to what is the preferred or the gold standard test, it is the RT-PCR or the CBNAT. Then you have the CRISPR mediated detection. I told you it is a gene editing technology. In India, it is called as Feluda technique. So it is operational validation is needed. It has not been validated as of now. Then the antigen detection test using the nasopharyngeal swab, it has a high specificity but a low sensitivity. So if an antigen test comes negative, you cannot rule out COVID and you will have to go for RT-PCR. However, an antigen positive patient can be treated as COVID-19 patient. So negative test does not rule out the infection and you will have to go on for a RT-PCR in such patients. It becomes a rapid point of care test, optimal in emergency setting. Then what is the incubation period of COVID-19 in children? So data for pediatric population are limited. However, the median incubation period is 5 days, which can extend up to 14 days, that is 2 weeks. Now, can COVID-19 infected child transmit infection before he has symptoms? Yes, definitely during the pre-symptomatic phase, that is a window period, also the patient can transmit the infection. The transmission of COVID-19 starts as early as 2 days before the onset of symptoms. Now coming to the type of clinical presentations, you have the pre-symptomatic patient, the asymptomatic patient, the classic manifestation, and the atypical symptoms. So coming to the pre-symptomatic, that is the time period between the exposure to the virus and development of symptoms. The child may be infectious during the pre-symptomatic period. Then the asymptomatic patients are the patients who have tested positive, but they do not have any clinical symptoms and the X-ray is normal. These children are actually identified during contact tracing because they themselves will not be having any symptoms. However, we have to remember that they are going to be infectious. Then coming to the classic manifestation, that is patient presenting with fever, cough, cold, sore throat, shortness of breath. And I told you in children, they could also present with GI symptoms. So there could be diarrhea, pain abdomen, etc. But this is indistinguishable from any other respiratory viral illness, and there are some atypical symptoms. Now, what are the atypical symptoms? As I told you, the GI symptoms, which could be a predominant feature in children without any respiratory involvement. So they include diarrhea, vomiting, pain abdomen. Then you have the cutaneous manifestation, which can occur in less than 3% of the children and could be an only feature of COVID-19. So there could be no other symptoms except for these cutaneous manifestations. So they could include maculopapular rash, urticarial rash, vesicular eruptions, and transient levodoreticularis. There is a peculiar thing called as COVID ptosis, which is more seen in children and young adults, which predominantly affects this particular age group. So it has reddish purplish nodules as shown in the pictures here, which occurs in the distal digits in the children and young adults. So this could be painful and pruritic or maybe painless. Excuse me. So these lesions could be seen in the digits. They could be painful, they could be itchy, or they could be asymptomatic discoloration. So you do not do anything, just supportive treatment is fair enough. At the most, you may require to apply some steroid creams. Then there is a unique manifestation, that is MISC, that is multisystem inflammatory syndrome in children. It will be discussed in detail in the coming sessions. It's a very important topic. Now coming to some of the recommendations. So these recommendations are going to be discussed in detail when we discuss about mild COVID management, moderate COVID management, and ARDS and severe COVID management. I'm just giving you a gist. So there is a strong recommendation for use of systemic steroids in patients with severe and critical COVID. So there is a recommendation for its use of steroids in only patients with severe and critical COVID, whereas there is a recommendation against the use of steroids in non-severe COVID. So all COVID-19 patients do not warrant steroid therapy. Only patients with a severe and critical COVID warrant steroids. Then there is a conditional recommendation against the use of remdesivir in hospital setting. That's why remdesivir hasn't to be used in all the patients of COVID-19 in children. There is a strong recommendation against hydroxychloroquine, ivermectin in pediatric patients. So HCQ and ivermectin have no role in pediatric COVID, nor does lopinavir or ritonavir. These antivirals also do not have any role in pediatric COVID. Now coming to the severity of how do you classify COVID-19 in children? So it is similar to that of adults. However, there are some differences. So mild illness would be any patient without any tachypnea. There's only sore throat, rhinorrhea, cough. And I told you in children, there could also be pain abdomen, vomiting, and diarrhea. So these children without any red flag signs, which we will be discussing later. So if these children do not have any red flag signs and they do not have tachypnea, they will be classified as mild illnesses. Now, moderate illness is patient with fast breathing, that is pneumonia. So you have age-based cutoffs in pediatric patients. There's no single cutoff for tachypnea in children. They are age-based. So in a children less than 2 months, a rate more than 60, 2 to 12 months, some respiratory rate more than 50, and 1 to 5 years respiratory rate equal to more than 40, and more than 5 years equal to or more than 30. So if this age-based cutoffs are exceeded, then you call it as tachypnea. So any patient having tachypnea with an oxygen saturation somewhere less than 94. So patient with mild illness will have saturations more than 94, whereas in moderate illness, the saturation may vary from somewhere around 90 to 94%. And they will not have any signs of severe illness. So they would be classified as moderate illness, that is basically pneumonia. Now, severe pneumonia will categorize as severe illness. So any patient with pneumonia who has a saturation less than 90 with cyanosis, with increased respiratory efforts in form of grunting or severe retraction, the red flag signs, as I told you, like lethargy, somnolence, seizures, yes, any of this, or a patient presenting to you with ARDS, sepsis, septic shock, and MOTS who is COVID positive will be treated as severe category. Now coming to mild disease, I already told you mild illness will present like any upper respiratory tract infection. They will not have tachypnea, they are not hypoxic. So the saturations are well above 94% on room air. Now, what are the cutoffs for tachypnea? I already told you. So let us learn it. It is less than 2 months, more than 60, 3 to 11 months, more than or equal to 50, 12 to 16 months, more than 40, and more than 60 months, that is more than 5 years, more than 30. So 30, 40, 50, 60. So some children may have no fever and have only GI symptoms, and physical examination may just show pharyngitis and no auscultatory findings. So there is no CREB, the X-ray is going to be perfectly normal in these patients. Now these patients are not going to be admitted, they are going to be managed as per home isolation. So patients with mild illness will be advised home isolation. However, they have to meet some criteria. So what are the criteria before you advise a patient for home isolation? So this is medical criteria. So the respiratory rate should be less than the age cutoff. That means the patient should not be tachypnic. The patient should not be hypoxic on room air. That is, the saturation should be well above 94%. And the patient should not have any comorbidities. Comorbidities may include, these are some of the comorbidities. Any comorbidities which require special attention has to be taken care of. That is cardiovascular disease, diabetes, immunocompromised status, chronic lung disease, chronic kidney disease, chronic liver disease, cerebrovascular disease, and obesity. So they should not be having any of the comorbidities. So then the social criteria which they have to meet is the patient should have a requisite facility for isolation at his or her residence, and also for quarantining from the family contact. So they should have a separate facility or a separate room when the patient can be isolated. Then there should be a caregiver who is able to provide care on 24/7 basis. Then they should have a country-specific app, that is Arogya Setu app. Then the parents or caregiver should have agreed to monitor health of the child regularly and inform his or her health status to the surveillance officer or the doctor. And the parents or caregiver must have filled an undertaking on self-isolation and shall follow home isolation or quarantine guidelines. So when all these social eligibility criteria are met and the patient is a mild illness case, then you can advise them home isolation. Now, which are the patients who have mild, despite of having a mild disease, we would like to admit? So if the social eligibility criteria is not met, wherein the home isolation is not feasible, like the patient is having a small house, or there is overcrowding, or a high-risk patient staying at home with inadequate facility, regular monitoring is not possible due to any reasons, then such patients will have to be admitted even though they are mild cases. Now, what is the duration of isolation? The duration of isolation in adults is 10 days of symptom-free, but in children, because they can shed the virus in stools, 2 weeks after the COVID negative report as a safer period of isolation. However, still the norms are 7 days only, but the children are known to shed the viruses in the stools for up to 2 weeks. Now, COVID-19 moderate disease, this we have already discussed. Any patient having tachypnea more than the age-based cutoff, but not having any signs of severe illnesses, and the saturation is well above 90. So more than 90, less than 94, then they would be categorized as moderate disease. Now coming to severe illness, this is also explained previous slide, that any patient with severe pneumonia who is having cyanosis, saturation less than 90, increased work of breathing in the form of grunting, severe retractions, there's lethargy, somnolence, seizure, patient presenting to you with sepsis, septic shock, MODS, that is multi-organ dysfunction syndrome, or an ARDS-like picture, then they would have to be categorized as severe illness. Now, just a brief about the management of patient with severe COVID. The details of this will be discussed in coming sessions. This is just a gist of it. So you have to admit all patients who are severe COVID-19. Preferably, they would require an ICU setting or a HDU setting, especially those who have ARDS-like picture or are having severe sepsis and septic shock. Then investigations has to be done, relevant investigations, which will be told in the coming sessions, has to be done, evaluate for thrombus, HLH, organ failure by appropriate investigations. Then all these patients with severe COVID would have to be given steroids. Remdesivir is only optional, that is a clinician's discretion. That will be discussed in later chapters when you have to use remdesivir. Ideally, we are not supposed to use in all pediatric COVID patients. Empirical antibiotics, see, it is a viral illness. Antimicrobial should not be misused in this particular scenario. Only if you are thinking of a sepsis-like picture or anticipating a septic shock, then you have to give empirical antibiotic. Appropriate cultures has to be sent. Oxygen therapy, all patients with severe COVID will require oxygen therapy. That is prong, face mask, HFNC and NIV. All this will be discussed in detail in the coming sessions. So which candidates would require a prong and which would require an NIV and an invasive ventilation. Restrictive fluid strategies have to be used because these patients are at a risk of myocarditis, that is cardiac involvement is common, especially in patients with MISC. So we would like to follow a restricted fluid therapy. Then some patients with severe COVID may also require renal replacement therapies and other form of organ support. Now coming to ARDS, so mild ARDS patients can be very well treated with a HFNO or a non-invasive trial, whereas severe ARDS patients will require mechanical ventilation. So mechanical ventilation strategy will be discussed in detail. We would require a low tidal volume, that is 6 ml per kg, and a high PEEP setting. So the PEEP would be high and the tidal volume would be less. And you are supposed to use a cuffed endotracheal tube for infection control. So cuffed endotracheal tube, though not routinely prescribed in all pediatric patients, but here in COVID-19, we would prefer a cuffed endotracheal tube for intubation. Fluid restriction, as I already told you, sedation depending upon the case scenario, it will be discussed in detail. And if poor response, then patient may also require prone ventilation, HFO and ECMO also. Coming to shock, shock in these patients is more likely to be septic shock or a cardiogenic shock. That is because of myocardial dysfunction. So the bolus would have to be given cautiously. So the crystalloid bolus, that is 10 to 20 ml per kg, would have to be given over 30 to 60 minutes. Only if the patient is definitely hypovolemic due to diarrhea or vomiting and you feel the patient is dehydrated and is hypovolemic shock, then the bolus can be given a little faster. Otherwise, you have to give it slowly, especially in patients who are anticipating myocardial dysfunction. Early inotrope support has to be advised and patients have to be monitored for fluid overload. Now, I'll be telling you the criteria for MISC. This topic is going to be very important and will be taken in detail in the coming days. So what is the case definition of MISC? So preliminary case definition, any child or adolescent in the age group of 0 to 19 years with fever for more than 3 days, and this fever is 100.4 degrees Celsius, say upper. So fever, persistent fever for more than 3 days with any two of the following: rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation of oral cavity, hands or feet with hypotension or shock. Then features of myocardial dysfunction, pericarditis, valvulitis or coronary abnormalities detected on echo, or elevated troponin and proBNP. Then evidence of coagulopathy in the form of elevated PT, APTT or D-dimers, and acute gastrointestinal problem like diarrhea, vomiting and abdominal pain. This can also be a feature of MISC. Along with that, there should be elevated markers of inflammation like ESR or CRP or a procalcitonin, with other causes of inflammation like sepsis, staphylococcal or streptococcal shock syndromes, local endemic infections like rickettsia, malaria, dengue, etc. has to be ruled out. And there should be a temporal association with COVID-19 in the form of a positive RT-PCR or an antigen test or a serology, that is past history of infection, because MISC can occur after an interval of 2 to 6 weeks. So serology sometimes may be positive, or there is a history of contact with COVID-19 patients. So the temporal association is also very important criteria. So here it covers the topic of COVID-19. So you will be learning about each of this in detail in the coming sessions. So I thank all the contributors of the program, and I thank Dr. Chandrakanta ma'am, Dr. Shelly ma'am for giving me this opportunity. Thank you.
Thank you, Dr. Vedika, for this wonderful lecture. And till now, there is no question for you in question answer box. I request participants that if you have any question related to any talk, you can just write in question and answer box or in chat box, and that will be answered. So Vedika, you just see the question answer box.
Yes,
and if there is any question related to your talk, you can just type your answer. So now I request Dr. Raj Kishore, Associate Professor from BRD Medical College, Gorakhpur, to take next talk on recognizing a sick child normal vitals, and triage. So welcome, Dr. Rajkishore.
Thank you, ma'am. Good afternoon, everyone. Am I audible or my slides are visible, ma'am?
Yes, Dr. Rajkishore.
Ji, ma'am. I am really very much thankful to Prajapati sir, Chandrakanta ma'am, and the whole team behind this great training session for preparation of COVID wave third. In this session, we will revise how recognizing a sick child, normal vitals, and how we can do trials. This one is very important part for, or it's a foundation for managing any COVID patient in your COVID facility. This one is very crisp presentation, very vital presentation, and we learn about vital signs, pulse oximetry, how to recognize a sick child, what are the red flag signs, and how to triage a COVID-19 pediatric patients. Our pediatrician colleagues are very much aware and really excellent in these all. But the non-pediatrician colleagues will really needs this session more. We will talk about temperature, heart rate, respiratory rate, and blood pressure. Normal body temperature ranges from 97.8 to 102 degree Fahrenheit. Fever is defined as temperature more than 100.4 degree Fahrenheit. Hyperpyrexia is temperature more than 104 degree Fahrenheit. I am repeating again, normal 97.8 to 100.2 degree Fahrenheit. Fever if more than 100.4 degree Fahrenheit, and hyperpyrexia if more than 100.4 degree Fahrenheit. Any abnormal rise in body temperature is considered as a symptoms of underlying condition. Highest temperature is reached in evening and is slightly lower in the morning. The heart rate varies as per age in pediatrics age group, and it also varies during awake and sleeping hours. And there is a chart as per age for awake heart rate and sleeping heart rate. But the most important point is to recognize bradycardia. And bradycardia is heart rate less than 60 beats per minute. And to recognize tachycardia, the heart rate in infant should be more than 220 beats per minute. In a child, should be more than 180 per minute. And in an adolescent, should be more than 100 per minute. Means less than 60 is bradycardia, more than 220 is tachycardia in infant, more than 180 is tachycardia in child, and more than 100 is tachycardia in an adolescent. This you have to memorize, especially our non-pediatrician colleagues. And we can make this chart and paste it in our triaging area for a smooth functioning of quality triaging. Now respiratory rate, like heart rate, respiratory rate also varies as per age. And the normal respiratory rate as per age is mentioned in the table. But what is really important in clinical scenario is how we can recognize the fast breathing. For a child, for an infant less than 2 months of age, if the breathing rate is more than 60 per minute, means it's fast breathing. For 2 months to 12 months of age, more than 50 per minute is fast breathing. For 1 to 5 years of age, more than 40 per minute is fast breathing. And for more than 5 years, more than 30 per minute is fast breathing. So we have to recognize in the clinical scenario, in our triaging area, our all paramedical supporting staff and all non-pediatrician doctors posted there should learn this, how they can recognize fast breathing. Less than 2 months, I am repeating this again because it's very important. For less than 2 months, more than 60 per minute. For 2 months to 12 months, more than 50 per minute. For in between 1 to 5 years, more than 40 per minute. And for more than 5 years of age, more than 30 per minute. Blood pressure is indirect surrogate marker of cardiac output. Hypotension is defined as blood pressure below the 5th centile for age. Fall of systolic blood pressure more than 10 mmHg is worrisome. But in pediatric population, unlike in adult population, hypotension is not synonymous with shock. Here in pediatric population, hypotension is a late and ominous clinical manifestation. Compensated shock will have normal BP with poor perfusion, and hence shock should be recognized in compensated state. And how we can categorize a hypotensive child, that the hypotension cutoffs varies as per age. For a term neonate, less than 60 mmHg is a cutoff for telling him hypotension. Term neonate, systolic blood pressure less than 60 millimeter of mercury is hypotensive. Up to 1 year, less than 70 mmHg is the limit for labeling hypotension. In between 1 to 10 years, there is a formula to know the cutoffs for hypotension. You have to add 70 in 2 times of the age. Means suppose a child of 8 years of age, for a child of 8 years of age, you have to add 70 plus 8 into 2 means 70 plus 16 means 86. So for 8 years of age, the hypotension cutoff systolic blood pressure should be below 86. It's very simple. For 10 years of age or more, the hypotension cutoff is less than 90 mmHg of the systolic blood pressure. So for term neonate, less than 60, up to 1 year, less than 70. In between 1 year to 10 years of age, 70 plus age multiplied by 2. And for 10 years and more, less than 90. pulse oximetry is very important for any hypoxic condition, any patients in ICU, and especially for our COVID patients. It measures oxygen hemoglobin saturation, assessed in children with respiratory, cardiac illness, and underlying abnormalities of oxygen. Healthy children have SpO2 more than 95, and underlying cause should be evaluated in children with SpO2 less than 93 to 95. The healthy children have SpO2 more than 95. But there are few caveats for pulse oximetry. It's a poor indicator of blood oxygen content and is tissue oxygen delivery. Does not indicate carbon dioxide status and efficacy of ventilation. It's a poor indicator of hyperoxia, and its utility is limited by poor perfusion status. If a child is having poor perfusion, the pulse oximetry reporting or data will be misleading and usually fallacious. And in these conditions, for these caveats of pulse oximetry, really we need a good ABG to assess the ventilation, efficacy of ventilation in a child. And there is a very good session on the coming days on ABG. Now, after knowing the various cutoffs of various vital signs like temperature, like heart rate, like breathing rate, and systolic blood pressure cutoffs, now we can recognize a sick child by following a structured approach which consists of initial assessment, primary assessment, secondary assessment, and diagnostic tests. During initial assessment, we will look for appearance, breathing, and color. Appearance, the child may look active, lethargic, even semi-comatose. Breathing, child breathing may be fast or normal. We can count the breathing rate and we can apply the various cutoffs as per each for fast breathing rate. The color of child, will assess color of child. Child may be pale, cyanosed, ashen gray, or normal. In primary assessment, we will go through A, B, C, D, E. A stands for airway, where we assess the airway is open and maintainable or not. B stands for breathing, where we assess the breathing rate. The child is breathing fast or not as per its age cutoffs, work of breathing, and SpO2. C stands for circulation, which is assessed by counting heart rate, capillary refill timing, blood pressure, peripheral pulses, color, and temperature. D stands for disability. This disability will be assessed by ABPU scale and GCS scale. GCS scale is usually for doctors, and ABPU scale is usually for your paramedic help in your triaging area. A stands for alertness, B stands for verbal response, P stands for response to painful stimuli, and U stands for unconsciousness. So your paramedical staff will label the child as A, B, or P, or U as per the patient status. But the accurate state of disability we can assess only through with GCS scale, and we have to paste the GCS scale in our triage area, and during further modules of this session, you will get very detailed insights about all this. E stand A, B, C, D, E. E stands for exposure, and exposure in a well-lighted area is a must to look for skin rashes, redness, swelling of hand and feet. In secondary assessment, we have to take focus history about fever, running nose, loose stool, poor feeding, and any positive contact history. And we go for focused examination from head to toe. And we will collect sample or do blood glucose, complete blood count, electrolytes, ABG analysis, liver function test, renal function test, coagulation test, inflammatory markers, and chest X-ray. After doing these all, after going through this structured approach to recognize a sick child, now we can evaluate the child in terms of if the child is lethargic, respiration is fast as per age cutoff, he is cyanosed, mottled, or ashen gray, SpO2 is less than 94 or normal, work of breathing is increased as indicated by the nasal flaring, chest indrawing, grunting. The child is having tachycardia or hypotension as per age cutoff. Extremities are cold or not, urine output is normal or not. Your patient is lethargic or unconsciousness or unconscious. There is skin rash or not. We can have a clear idea about fever, sore throat, rhinorrhea, loose stool, stomach ache, redness and swelling of tongue, redness and swelling of hand and feet are very important to observe by proper exposure in a well-lighted area. Oral mucosa is dry or sunken eye. Is there sunken eye as a part of dehydration? And we can assess skin pitch. It may be very slow, slow, or immediate. Very slow means more than 2 seconds. Slow means less than 2 seconds, skin pinch, and immediate means immediate. After recognizing a sick child, after being master of the various cutoffs of the vitals as per age, we have to recognize the red flag signs and general danger sign in our pediatric patient presenting to our emergency or COVID emergency especially. We have to put these red flag signs and general danger signs on our file. So what are those red flag signs are? Fever more than 100.4 or more than 3 days. SpO2 less than 94. Cyanosis. Respiratory rate more than cutoff for age. Means 60, 50, 40, and 30. Presence of chest indrawing or not. Feature of MIS. There is a very good lecture on MIS during coming days of this training. Now, what are the general danger signs? Not able to breastfeed or drink is really a danger sign. Vomit everything, convulsion, lethargy, or unconsciousness. You have to note down if any one of the red flag signs or general danger sign is present in the presenting child, triaging area. After doing these all, we can trace the child presented to us as per his temperature, SpO2, presence of contact with recent or current confirmed COVID-19 cases, his symptoms, and we can do sample collection at the time of admission for recognizing child status at time of presentation. And after this all, we have to categorize our patient in mild, moderate, and severe cases. And it's very simple, very simple. If SpO2 is normal, respiratory rate is not fast, work of breathing is not increased, no cyanosis, no circulatory insufficiency, no general danger sign, the patient should be categorized as a mild case. If your patient is having fever, respiratory rate is fast as per age-based cutoff, but work of breathing is not increased, cyanosis is not present, circulatory insufficiency, no, danger sign, no, and SpO2 in between 90 to 94 means less than 94, less than 95. So that patient should be categorized as a moderate case. And if a patient SpO2 is less than 90, his work of breathing is increased, respiratory rate is fast, fever is present, but cyanosis, circulatory insufficiency, and general danger signs may be present, may not be present. That patient should be categorized in severe case. So in severe case, SpO2 is less than 90 and work of breathing is increased. In moderate case, SpO2 is in between 90 to 94, but work of breathing is not increased. And in mild case, SpO2 is more than 95, work of breathing is not increased, respiration rate is also not fast. After categorizing your patient, you have to note, you have to take history about comorbid condition and write down this. The important comorbid condition you have to ask for: diabetes mellitus type 1 and rarely type 2 also in a very obese children, cardiac diseases, congenital heart diseases, chronic lung diseases, chronic kidney diseases, or dialysis, chronic liver diseases, neurological disorders, psychiatric illness, obesity, severe malnutrition, steroid therapy, chemotherapy, and cancers. So we have to note down presence or absence of this comorbid condition in the presenting child. And after doing this all, we can place our patients appropriately in a COVID facility for a better outcome. If the severity of illness is patient is asymptomatic or is having mild disease and there is absence of comorbidities, place that patient in quarantine facility or home isolation. If your patient is having moderate illness or there is presence of comorbid condition, place that patient in COVID STU. If your patient is having severe illness or MIS, place that patient in pediatric ICU, COVID pediatric ICU. Now, in conclusion, we can tell that assessment of vital sign is critical. Age-appropriate cutoffs should be known, basically for our non-pediatrician colleague and for our paramedicals. All cutoffs for every vital should be printed and pasted in a triage area for smooth and effective functioning of the triage area. All danger signs, all red flag signs, all comorbidities should be printed and pasted in your triage area for effective functioning. Recognizing a sick child can be done by a structured approach, initial assessment, primary assessment, secondary assessment, and the sampling, pathological sampling. Evaluation comprises of initial assessment and everything. COVID-19 patient can be classified into mild, moderate, and severe cases based on the evaluation. Red flag signs, general danger signs, and comorbid condition must be also assessed. And these all are must for placing your patient by doing a good triage. And we have to learn a skill and enhance our skill about how to count respiratory rate, how to record BP, how to record auxiliary temperature, and how to use pulse oximeter, and what are the caveats in using pulse oximeter. These are the references, and my sincere thanks to the organizer, to the all contributors from different institutes like DGME office, KGMU, SGPGI, RML Institute, IMS BHU, AIMS Raebareli, SSPH PGTI Noida, and SRMS Bareilly. Thanks a lot, everyone. Is there any question, ma'am?
Thank you, Dr. Raj Kishore, for explaining everything so beautifully that I think everything is clear and there is no question. But you can continue to see the chat box. If there is any question related to your talk, then you please answer. So thank you, Dr. Raj Kishore.
Thanks, ma'am. Thanks.
And we now proceed to our next talk. Next talk will be delivered by Dr. Vijay Yadav. He is Associate Professor at Government Medical College, Ambedkar Nagar. And he will be talking about the management of mild COVID in children. So Dr. Vijay Kumar Yadav, please start.
Good afternoon, ma'am. Am I audible to all?
Vijay, you are audible.
And I'm sharing my screen. Is it visible?
Yes, yes, it's
visible. Okay, thank you, ma'am. Thank you, Naganta ma'am, for this opportunity. And thank you, DGME office, Dr. N.C. Prajapati sir, Dr. Sally ma'am, and all the organizers for this opportunity. My topic for the day is management of mild COVID-19 in pediatrics and how will you monitor the children during home isolation. What are the learning goals of this session? At least we should be able to identify what are the mild COVID infection, clinical features of mild COVID in pediatrics, and what are the red flag signs, what we have to do, what we have to avoid, and how will you monitor during home isolation, what is the feasibility for home isolation, and how will you treat symptomatic treatment during mild COVID, and if patients are suffering from comorbidities like CKD, CLD, congenital heart diseases, how will you be able to treat and what are the red flag signs so that you can either identify for admission or you can refer to the higher center. What are the clinical features of mild cases? As we have already dealt in the two waves, mild COVID in also presents like fever, sore throat, rhinorrhea, that is running nose, cough, diarrhea, and vomiting. But there will be no fast breathing. Age appropriate tachypnea has to be absent. Already we have discussed what is the age appropriate tachypnea that we deal in the classification of COVID and triaging. These are clinical features of mild COVID, that is fever, that is more than 100.4 degrees Fahrenheit or more than 38 degrees centigrade, sore throat, rhinorrhea, cough, coryza, diarrhea, vomiting, pain abdomen. As we have already discussed in previous sessions, that is patients can be managed at home with home isolation facilities, and we have to provide only supportive treatment. We don't have to be very aggressive. In home isolation, we have a few criteria that patients can be managed at home if we are having the feasibility for home quarantine facility. What are the home isolation feasibility criteria? First of all, there has to be the facility for isolation at his or her residence patient, and also for quarantining the family contact, so that these patients can be managed at isolated places, and parents or caretaker who can monitor and take care of the child. Parents has to be like this, so that they can at least monitor their child and inform if there is any deterioration or there is any red flag signs. If available, Arogya Seti app should be downloaded. The parents, one more thing is that parents has agreed to monitor the health of the child and regularly inform health stated to the surveillance officers or their doctor. The parents has filled an undertaking on self-isolation and should follow the guidelines for home isolation as well as our quarantine guidelines, and should follow COVID appropriate behavior at home. What are the supportive treatment? As I already said, that is management of mild COVID in pediatrics is totally symptomatic. We have to monitor the child and treatment according to symptoms. Like if patient is having fever for more than 38 degrees centigrade or more than 100.4 degree Fahrenheit, paracetamol has to be given every 4 to 6 hourly at the dose of 15 mg per kg per dose. For pediatric patients, you have to give syrup, then you have to know what is the concentration of the syrup. For cough, we can give throat soothing agents like lukewarm water. And in adolescents and older children, we can go for normal saline gargles. And patient has to be well hydrated. We have to give adequate amount of oral fluids to maintain the level of hydration, as well as diet has to be nutritiously of high value. We have to maintain COVID appropriate behavior of your guidelines, like we have to maintain 2 feet distance, and we should monitor the patient accordingly. How will you manage mild cases with comorbidities? If patient is having comorbid conditions like congenital heart diseases, chronic lung diseases, CKD, chronic liver diseases, or obesity, that is body mass index more than 2 standard deviation, these patients also can be managed at home with good quarantine facilities. But if any deterioration is there in the clinical features, or there is no proper arrangement for managing the child at home, the patient needs to be admitted either in the healthcare facility. How will you monitor? For monitoring, we should have what are the parameters that needs to be monitored, and how will you monitor? We should have a paper or a diary so that we can record the daily data. We should be able to monitor what is the respiratory rate. Respiratory rate should be monitored 2 to 3 times a day, especially when the baby is not crying, when either the patient is sleeping or a bit in the resting position. Or also we should monitor what is the level of activity, what is the fluid intake of that patient, and what is the urine output, and how will you and what is his or her oxygen saturation level. That has to be monitored by handheld pulsimeter. We should also look for the danger signs like chest indrying, nasal flaring, any signs of paleness of the body, either cyanosis or increasing pallor, cold extremities. We should be able to monitor these danger signs, and these danger signs has to be at least corresponded to their family physician, or parents or caretakers should know whom to contact and when to contact. Then when means at least we should able to know what are the danger signs of this mild COVID, so that patients either turning into the moderate COVID or severe COVID, so that patient can be shifted to the healthcare facility, either in COVID ICU or HDU. How will you monitor this respiratory rate? We should able to count the respiratory rate, as everybody is well aware of the respiratory rate. What is the cutoff for tachypnea, age appropriate tachypnea, as already we have seen in the previous session that is taken by Dr. Rajkishore. And count, how will you count respiratory rate? respiratory rate should be counted for at least 1 minute. If that is more than is appropriate, like if patient is of 2 months to 12 months, yeah, 1 year, tachypnea is respiratory rate of more than 50 or more than 50. If more than that, that is patient is having tachypnea. The patient has land up in moderate COVID. Then we should be at least able to recognize that with time and monitor so that we can shift the patient. Also, we should be able to measure temperature. Patient is many times neonatal infants can be hypothermic. So we have to keep a watch of increasing temperature or decreasing temperature. SpO2 should be normally more than 94% in the mild COVID. Less than 94, we should be red alert. And we should also look for the chest drawing, nasal flaring, cold extremities, cyanosis, increasing pallor, what the level of activity, what is the level of feeding, either breastfeeding or dietary intake, what is the level of hydration. We should be able to monitor urine output, level of skin pinch, eyes, skin turgor. These, at least we should be able to recognize these points and able to maintain a chart so that we can at least able to recognize the child in early stages of the mild COVID to moderate COVID, so that the patient may not land up in directly in severe COVID, yeah, ARDS. These are monitoring chart that can be monitored. There are few parameters. At least we should monitor these parameters 2 to 3 times a day. If patient is not able to improve, not improving from last 2 to 3 days, then we can at least monitor frequently. Like respiratory rate, what is the respiratory rate per minute? What is the level of SpO2? What is the temperature? Hypothermia, hyperthermia, hyperpyrexia. Temperature is more than 100.4 degree Fahrenheit, this is fever. If more than 104 degree Fahrenheit, this is hyperpyrexia. I think everybody is well aware of these entities. But chest retractions, these are the signs of pneumonia, severe pneumonia. Nasal flare, present or absent. GI symptoms like nausea, vomiting, diarrhea, pain abdomen. At least many times pediatric COVID patients can present with only GI manifestations. We should be able to know what is the level of hydration, what is the level of urine output. Urine output should be more than 0.5 ml per kg per hour. And other features, if you are able to recognize patient is having seizures, cyanosis, letharginess, somnolence, decreased activity, irritability, refusal to feed if patient is of less than 1 year of infant or neonate. At least these are the parameters that needs to be monitored regularly. If any deterioration in these parameters, then patient needs to be shifted to the healthcare facility, either in HDU or ICU, according to category. Patient is having mild COVID, moderate COVID, or severe COVID. As already told, mild COVID is almost clinical diagnosis, and we don't need any specific investigations to deal with. There is no role of chest X-ray or CT scan. Though no antibiotic is required for mild COVID. Steroids are also not indicated in mild COVID. If patient is deteriorating, can patient land up in severe COVID, then these drugs can be used. And there is no role of hydroxychloroquine, favipiravir, ivermectin, lopinavir, ritonavir, remdesivir, and other immunomodulators like IVIG, yeah, interleukin-6 modulators, and tocilizumab, interferon, or convalescent plasma don't have any role in mild COVID. In mild COVID, what the most important point is, at least we should able to recognize mild COVID, and we should able to deal with them either in the home facility or in the quarantine facility. And we should know what is the red flag signs when we have to admit the patient or refer to the higher facility, so that any mishappening can be avoided. What is the red flag signs? Red flag signs is if patient is having persistent fever lasting for more than 3 days, that is more than 100.4 degree Fahrenheit for more than 3 days. If patient is having fast breathing, that is tachypnea, is appropriate tachypnea, that is already told. If patient is having tachypnea, either the patient is having percentage of age less than 2 months, tachypnea is 60 or more respiration per minute. If patient is of less than 1 year for more than 2 months, more than 50 per minute is tachypnea. 1 to 5 years, more than 40 per minute is the tachypnea. More than 5 years, more respiratory rate more than 30 per minute is tachypnea. Another red flag sign is SpO2 less than 94%. These are the red flag signs. Persistent drowsiness, letharginess, poor feeding. A patient is having very poor intake, patient is having letharginess or drowsiness, patient is having cold extremities, patient, these may be signs of impending shock. Urine output, if low urine output is low, less than 0.5 ml per kg per hour. In small children and infants, at least urination has to be 6 times a day. If there is skin rash, eyes are red, pale or congested, gray, a blue skin, there is signs of cyanosis. These are the red flag signs. Then you have to shift the child to the healthcare facility for admission as well as appropriate management. Now these are the references. These are the few skills that needs to be enhanced in case of you are dealing with mild COVID patients. You should know how to count respiratory rate, what is the normal respiratory rate, what are the cutoff for tachypnea, and you will able to record the temperature, this rectal temperature, or oral temperature, axillary temperature. Rectal temperature is more than oral temperature. Oral temperature is more than 0.5 degree than axillary temperatures. The cutoff is usually according to oral rectal and oral temperature. You have to recognize what is the level of assessment of hydration status. If patient is very hydrated, yeah, patient is having poor hydration. If patient is having severe acute malnourished, yeah, patient is of severe acute malnutrition, SAM, then tough assessment of hydration may be tough. So you should able to assess all the criteria of hydration, urine output, intake, respiratory rate, and what are the red flag signs. That is already I have mentioned. What are the respiratory flag signs like persistent temperature, yeah, is appropriate tachypnea, yeah, cyanosis, increasing, yeah, respiratory efforts. These are the red flag signs. So patient can be shifted to the upper facility for management. Thank you a lot. And thank you all the organizers, Dr. Anshi Prajapati sir from DGME office, all the staff for DGME, Dr. Saliosthi ma'am, Dr. Rachandkanta ma'am, and our seniors like Dr. A.K. Yadav, Dr. Mala ma'am. And thank you for this wonderful opportunity. I'll be highly grateful for the next opportunity as well as. Thank you. Any queries?
Thank you, Vijay. And let me see, is there any question? Okay, so there is only one question. How to assess hydration of the child? I think you have discussed this in your talk also, but you may repeat it. How to assess hydration of the child?
In pediatrics, any vital signs or hydration has to be assessed according to age. Suppose patient is of less than 2 months or more than 1 year. So first of all, we have to assess the vitals like heart rate, respiration, blood pressure, as well as skin turgor, eyes may be dry, skin may be, pinch may be very slow, then skin pinch, more if that is capillary refill time. If less than 2 seconds, that is normal. More than 2 seconds and 2 to 3 seconds is borderline. More than 3 seconds is definitely abnormal. And mucosa, tongue, oral mucosa, tongue, as well as tears, level of tears, if very less, patient is irritable or crying, and his mucosa or his or her mucosa is wet, not wet, patient is having poor hydration. Hydration may be dehydration, may be no dehydration, some dehydration or severe dehydration. That depends upon these entities. And you should monitor also blood pressure as well as urine output for the level of hydration. Like already discussed in the previous slide, in the previous session, what is the level of hypotension? If patient is less than 1 year, less than 70 millimeter of mercury is hypotensive. If patient is more than 1 year, cutoff is 70 plus age into 2. That is like patient is of 5 years. Then 70 plus 5 into 2, more than 80 millimeter mercury of, that has to be systolic blood pressure. If less than 80 millimeter mercury in age of 5 years, that is patient is a hypotensive. And we have in pediatric population, at least we should know the criteria of any vital according to age group, like less than 2 months, less than 1 year, or infants, more than 1 year, more than 5 years, so that at least we should have a rough estimate of heart rate, respiratory rate, blood pressure, SpO2 monitoring, temperature, and for dehydration, we should be able to skin turgor kya hai, what is the skin turgor, and oral mucosa, eyes, and all that. Thank you, ma'am.
Okay, and one more question, how much should be the urine output? I think in general we take more than 1 ml per kg per hour. But
normally more than 1 ml per kg per hour, that has to be. If less than 0.5 ml per kg hour, then this is definitely going in the phase of oliguria. We should be alert.
Oliguria. Okay. So okay. So
Thank you, ma'am.
there's no other question for you. So thank you, Vijay.
Thank you, ma'am.
And our participants must be feeling hungry by now. So we take a break for 20 minutes, lunch break. And exactly after 20 minutes, okay, so at 2:10, we will again start our session. So we stop here and we will again start our session after lunch at 2:10 sharp. So now we start with our next session, and our next speaker is Dr. G.S. Chaudhary, and is professor from GMC Jalon, and he will be talking about the management of moderate COVID in children. So I request Dr. Chaudhary to please start.
Thank you, madam. Am I audible and my slides are visible?
Yes, your voice is audible and slides are visible.
Okay, thank you, madam. A very good afternoon to one and all present here. First, I thanks to DGME sir, Prajapati sir, Sally madam, Chandrakanta madam, and entire team for giving me opportunity to talk about this. So many things are discussed since morning about the COVID. So topic allotted to me is management of moderate COVID in children at level 2. There are many guidelines about the adults, but very few are about the children. And we are thinking that third wave may affect the children. So we should prepare about the management of COVID. So about the moderate COVID, what are our goals? To identify level of the severity. So by deciding the level of the severity, we decide what should be the mode of management. Where to manage, whether in the hospital or at home. So our second goal is where to manage moderate COVID children, home or hospital. Third is how to monitor. Monitoring is the key of success of any treatment. So how to monitor moderate COVID children, we'll discuss here. And when to investigate, whether we investigate all the children or few children, and what are the investigations we should do. When we give fluid, and if fluid is given, in which form, oral or IV or any other form. When to give oxygen, and how to give oxygen, and how much oxygen should be given, we'll discuss here. So before assessing the severity, first we diagnose. So diagnosis of COVID children, when there is influenza-like illness, fever, rash, diarrhea, abdominal discomfort, cough, we suspect COVID, and we go for antigen test. And if antigen is positive, it is positive COVID, confirmed COVID case. And if it is negative, it doesn't rule out COVID. So we should go for RT-PCR. And if RT-PCR is positive, then it is confirmed case of COVID. But if it is negative, then it is confirmed case of COVID negative. But if there is strong suspicion, if there is doubt of COVID, if there is peak of COVID, in that time, if there is family members are involved with COVID. So if there is a strong suspicion, a strong doubt, then we should go for repeat RT-PCR or CT test. So assess the severity of COVID in children. COVID is divided in 4 categories in children. First is mild, moderate, severe, and critical. In mild COVID, there is sore throat, running nose, cough, loose motion, vomiting, abdominal pain, discomfort, mileage, etc. But there is no fast breathing. So in mild case, there is no fast breathing, only mild symptoms of sore throat, cough, cold, etc. are there. But apart from these mild symptoms, If child is having fast breathing, then it is moderate COVID. Fast breathing is defined as in children age-based criteria. If any child is having respiratory rate 60 or more in age group 2 months, less than 2 months, and in children 2 months to 12 months, if respiratory rate is 50 or more, it is tachypnea. Children between 1 year to 5 years, if respiratory rate is 40 or more, it is tachypnea. And children above 5 years, respiratory rate 30 or more is tachypnea. And if oxygen saturation is between 90 to 94%. So if these criteria are present, then child is in moderate COVID. But there should not be any sign of severe pneumonia. So child with signs of mild disease plus fast breathing is classified as moderate COVID. What are the signs of severe pneumonia? We'll discuss later. So severe disease is also defined as severe pneumonia. In severe pneumonia, there is, apart from the cough, cold, fever, and fast breathing, that means pneumonia, child is having cyanosis, desaturation, oxygen saturation below 90%. In moderate COVID, it is 90 to 94%. There is increased respiratory efforts, that is defined as presence of grunting, severe retractions, chest indrawing. So, and other things are like lethargy, somnolence, convulsions. If child is not able to take anything orally, and child vomits everything, whatever we give the child vomits, then these children are classified as severe disease. We may not get all the things in one child, so any one of these are in combination may present in one child. So if any one of these is present, child is classified as a severe disease. In critical disease, child is having acute respiratory distress syndrome, sepsis, septic shock, multi-organ dysfunction syndrome, acute thrombosis, multi-system inflammatory syndrome in children. So severe disease and critical disease are discussed in coming days. I will discuss here only moderate disease. Mild is discussed in previous lecture. How will manage moderate COVID? So ideally moderate COVID children should be admitted in hospital and preferably in HDU. If child is severely ill, that child should be admitted in ICU, but moderately ill children should be managed in HDU. And there is no specific treatment, only supportive treatment is given along with oxygen therapy. So supportive treatment and oxygen therapy is the mainstay of treatment of moderate COVID. But monitoring is very, very important in moderate COVID children because they may change from moderate to severe disease. So monitoring 4-hourly is essential in case of moderate diseases. And we should monitor sensorium, pulse rate, pulse volume, respiratory rate, any signs of distress like retraction, head nodding, nasal flaring, grunting, blood pressure, oxygen saturation, liver size, urine output. So these things should be monitored 4-hourly interval. And if child is deteriorating, then more frequently. What are the investigations we should do in moderate COVID children? So we should admit moderate children in HDU and we should do primary investigations. Primary investigations in all children, admitted children, like CBC, liver function test, renal function test, CRP, X-ray chest, and blood culture if suspecting bacterial infection. And if child is not improving and deteriorating, then more investigations are required, like coagulation profile that include PT, APTT, D-dimer, serum ferritin, PCT, procalcitonin, CPK, ECG, and echocardiography. So these investigations are not required in all children. If child is deteriorating, then it is required. Basically, these investigations are required in all children. Fluid, whether it should be given either in form of oral or IV fluids. So we should ensure or encourage adequate oral intake. So we should prefer oral fluid in case of moderate children, moderate COVID children. If child is able to take orally and not vomiting, we should correct dehydration. Many times these children is having diarrhea, vomiting, and not able to take orally, so they may go in dehydration. So we should manage dehydration according to WHO plan A, B, C. In WHO, we divide the dehydration in no dehydration, some dehydration, and severe dehydration. If child is having no dehydration, we manage as plan A. That means we give homemade fluids. If child is having some dehydration, we give ORS. And if child is having severe dehydration, we give plan C like IV fluids. If child is unable to take orally or poor oral intake, in those children we prefer to give IV fluids. And amount of fluid for maintenance is, if child is less than 1 year, that means infant, then 150 ml per kg per day. So in 24 hours, we give 150 ml per kg in children less than 1 year. And that should be given preferably by infusion pumps. Children more than 1 year, first 10 kg we should give 120 ml per kg per day. Then for next 10 kg, we give 50 ml per kg per day. And for next 10 kg, we give 20 ml per kg per day. That means if any child comes to us having weight of 15 kg, then for 10 kg we calculate by 120 ml per kg, that means 1200 ml. And for 5 kg we calculate by 50 ml per kg. So that will come to 50 ml. So total will 1450 ml. So for 15 kg child, we should give fluid 1450 ml. Similarly, if child is more than 20 kg, we calculate for 20 kg we give 1500 ml, and for suppose 25 kg we give 100 ml for 5 kg by rate of 20 ml per kg. So it will come 1600 ml. 1800. For 20 kg 1700, and for 5 kg 100 ml. So total it will come 1800. What are the types of the fluid we should give? Nowadays, isolate P is not used. We should prefer N/2 with dextrose. And if it is not available, then we should prepare half volume of 10% dextrose and half volume of normal saline. We can also use DNS containing 5% dextrose and normal saline. And if we give fluid for more than 24 hours, then we should add potassium chloride. But potassium chloride should not be added in higher quantity. We should add 1 ml in 100 ml of the fluid, not more than that. Isotonic, isolate P is hypotonic, so it should be avoided. Antibiotics. We know that COVID is a viral illness, so antibiotics are not antiviral, so we should avoid antibiotics. But if there is a strong suspicion of co-infection with bacteria, or it is evidence of bacterial infection by investigations, so we should use antibiotics in those cases. And preferred antibiotic is amoxicillin. First choice is amoxicillin. The dose of amoxicillin is 30 to 40 mg per kg per day, divided in 3 doses, 3 equal parts. And we can upgrade antibiotics like amoxiclavulinic acid, or in combination with ceftriaxone and other antibiotics, depending on the organism, suspected organism. Another mode of treatment in moderate COVID is nebulization. Many times there is bronchospasm and presence of wheezing is there. So if there is wheezing is present, only then we should nebulize. Otherwise, we should avoid the nebulization. But nebulization is also potentially dangerous because it generates aerosols and spread infection more. So we should avoid traditional nebulization. We should prefer MDI. MDI is these inhalers with spacers and mask. So by this, less chances of aerosol generation and less spread of COVID. But if nebulization is essential or MDI is not available, spacer is not available, we should go for nebulization. But we should cover the face of child, mouth and nose of the child with mask, 3-ply mask. For nebulization, we should use acetylene respiratory solution that contains 1 ml of that contains 5 milligram of salbutamol. We should take 0.5 ml of this and add 2.5 ml of normal saline. So make it 3 ml, then we should nebulize with respiratory solution, acetylene respiratory solution. But nowadays, we are getting these respules. Respules are already diluted. So 1 ml of these respules, acetylene respule contains 1 mg of salbutamol. So, and it is of about 2.5 ml. Total volume of one respule is 2.5 ml. So it contains 2.5 mg of salbutamol. So it need not be diluted. It should be used full respule at a time. Then comes oxygen therapy and modes of oxygen therapy. If there is desaturation, that means oxygen saturation is less than 94% and there is increased distress, then we should supplement oxygen, and our target should be more to maintain oxygen saturation above 94%. We should also try awake proning because moderate children are not that sick. So awake proning is very much feasible in older children. So we should try awake proning in moderate COVID children, and we should change the position every 2 hours. Mode of oxygen therapy, there are 3 modes of oxygen therapy. One is nasal prong, and other is face mask, and third is non-rebreathing mask. So by these 3 modes, we use to provide oxygen in children with moderate pneumonia. But if child is having severe pneumonia, that means in severe category, then we can use high heated humidified high flow nasal cannula, S3FANC, heated humidified high flow nasal cannula, or we can use CPAP, BiPAP, ventilators, invasive ventilators. So these modes of oxygen delivery are required in severe cases. So coming to the first mode in moderate cases, that is nasal prong. This is nasal prong, having 2 nasal air supply from here, and it is coming in 4 sizes: neonatal, infant, pediatric, and adult. And the quantity of oxygen flow should be given by this is 0.5 to 4 liter per minute. So by nasal prong, we should not give more than 4 liter per minute. And by this, we can provide oxygen FiO2 30 to 40%. So by this nasal prongs, if child is having mild distress, we can give by this nasal prongs. Second mode of oxygen therapy is face mask. These are the face, this is face mask. And this is also coming in 4 sizes. Neonatal, infant, pediatric, and adults are 0, 1, 2, 3. Oxygen flow rate by in this is little higher, 5 liter to 8 liter. So by face mask, we can give oxygen 5 liter to 8-9 liter per minute. And by this, we can give little higher oxygen concentration, that is 30 to 60%. So FiO2 we can deliver by this face mask, ordinary face mask, is 30 to 60%. Then third mode of oxygen therapy in moderate COVID cases is non-rebreathing masks. There is attachment of reservoirs. So by this we can give little higher oxygen. And it is also coming in 3-4 sizes: neonatal, infant, and pediatric size, or S, M, and L size. Oxygen we should give by 9 liter to 15 liter by this. And FiO2 child will get by this is 40 to 90%. So by these 3 modes, in first mode by nasal prongs we give 0.5 to 4 liter. By second mode, that is face mask, ordinary face mask, we give 5 to 9 liter per minute. And by non-rebreathing mask, we give 9 liter to 15 liter per minute. Then comes other mode of treatment is steroid, low molecular weight heparin, and remdesivir. Steroids are not recommended in moderate cases. It is recommended in severe and critically ill children. And it improves survival in severe to critical cases, not in moderate cases. Anticoagulants are not recommended for prophylaxis in any severity of COVID, but it can be used if there is established thrombosis. So if there is evidence of established thrombosis, then anticoagulants, low molecular weight heparin should be used in children. Otherwise, low molecular weight heparin should be avoided in all the severities of the cases. Dose of low molecular weight heparin, that is enoxaparin, is 1 milligram per kg per day, subcutaneous, once a day for 10 days. Then comes injection remdesivir. Remdesivir should be avoided in children, especially in moderate cases, but it can be given in case of rapidly progressive disease if child comes before 7 to 8 days. And dose of remdesivir in children above 40 years is as in adults, 200 milligram on first day as a loading dose, followed by 100 milligram from second to fifth day. In children below 40 kg, remdesivir should be 5 milligram per kg as a loading dose.
लेकिन सब जितने छोटे हैं ना सब हमको टीज करते रहते हैं,
followed by 2.5 milligram per kg.
समझ नहीं आया मुझे, पूछूंगा मैं उसको, लेकिन ऐसे मुझे सब टीज करते हैं. वैसे प्रीति कम करती है, रुचिका, सुरभि, कुछ तो कुछ में जैसे छोटे बच्चे करते हैं ना वैसे टीज.
Please mute yourself.
अतुल.
Favipiravir, tocilizumab, hydroxychloroquine, chloroquine, ivermectin, azithromycin, lopinavir, rotenavir should be avoided. These are not recommended for management of COVID in children. What are the discharge criteria? So moderate COVID children should be discharged after 10 days of onset of symptom, but there should be clinical resolution of the symptom, and child should maintain oxygen saturation above 95% of oxygen for at least 3 days. So we should discharge moderate cases after 10 days of onset of symptom, but there should be resolution of symptom completely, and there is maintaining oxygen saturation above 95% for at least 3 days, followed by home isolation for 7 days. These are the references of this presentation. Skill to be learned here that should be enhanced is recognition of danger sign and severity of disease or pneumonia. to assess the severity of pneumonia. And what are the skills to give oxygen therapy? What are the modes of giving oxygen therapy? Thanks to all contributors, DGME sir, DGMH sir, KGMU, SGPGI, RML, Lucknow, IMS BHU, AIMS Raebareli, SSPH, PGTI Noida, SRM Bareilly, and all the contributors. Thanks a lot. And thank you all for your patient listening. If any question is there, I'm ready to answer. I'm happy to answer.
Thank you, Dr. Chaudhary. And there is only one question for you. So Dr. Jaiparam has asked the role of procalcitonin and ferritin. So what is the role of ferritin and procalcitonin?
These are acute phase reactants. So if these are increased, especially procalcitonin, that indicates evidence of bacterial infection. That is supportive for bacterial infection. In those cases, we provide antibiotics. Ferritin is also acute phase reactants. It is not frequently used. Before this, we should go for CRP. If CRP is increased, mostly this ferritin is also increased. It is also similar to acute phase reactant of CRP. So there is evidence of inflammation. These are evidences of inflammation.
Thank you, Dr. Chaudhary. And there is no more question for you. Thank for the excellent presentation. So now I invite Dr. Neeta Radhakrishnan, and she is from Super Specialty Hospital, Noida. And she will be talking about the interpretation of chest X-ray in relation to pediatric COVID. So welcome, Dr. Neeta.
Thank you, ma'am. Before I start, I would like to thank DGME for this opportunity and to all the contributors of these slides. So the next session, in the next 20 minutes, we will be discussing interpreting chest X-rays in the context of pediatric COVID. Some of the images have been cited from literature, so the relevant references have been given in the slides. So what will we see in the order in which what we'll discuss this would be: 1, how is an X-ray in a pediatric COVID situation different from our routine X-rays? The routine X-ray which we are going to order from our OPDs or from an emergency. The pediatric patient usually goes to the radiology department and gets the X-ray, probably gets it reported from the radiology department and brings it to us. So that would be different in a pediatric COVID scenario, because in mostly COVID, whenever there is a symptom, you get tested, and once with the test, you go to the COVID ward, get admitted, and then you don't come out till you are better. So most of the X-rays we take are generally portable X-rays, and in many cases, the X-rays are seen by the clinician then and there, and it is not sent for reporting. So all the more reason we should be aware of the surface anatomy, we should be aware of what are the abnormalities that are there, and that is what we are going to see. We'll also see how a pediatric X-ray differs from an adult X-ray, what are the normal outline and landmarks. We'll see what are our X-ray abnormalities of concern in COVID-19. And finally, when should we be ordering X-rays or CT scans in children with COVID-19? So, like I said, most cases, it would be a portable X-ray. So the projection would be AP. And when we do an AP projection, what we should know is that lung fields are not very good for reporting, but still we have to manage. Cardiac shadow usually appears a little larger than normal. So then again, if you have a child who looks like having a cardiomegaly on an AP projection X-ray, then you should interpret it with caution. Maybe ask for an additional investigation, another investigation, probably like an echo or something, if you are suspecting cardiomegaly. Second, these are bedside X-rays and mostly supine films, because children will be in respiratory distress, they'll be lying down. And many times in pediatric X-rays, children will be crying when you try to restrain them. Because of it, it would be expiratory film. So children cannot hold their breath while an X-ray is being taken. So expiratory film, supine film, all of this can have problems while reporting. So when you have a supine film, again, cardiomegaly may be apparent. And supine film, minimal amount of pleural effusion can be missed on supine films because the fluid goes up. There is no gravity to see it on the postophrenic or cardiophrenic angles. So that again could be missed. And many times if you have a crying, struggling child, it can be rotated. The film may be rotated also. And in which case, again, rotated film, lung parenchyma will not be good for reporting. The lung zones won't be good. And minimal amount of the other way around also. If it is a rotated film, minimal amount of lucency can be falsely seen. It may not be because of any abnormality, it may be just be because of the rotation per se. So all these things should be kept in mind while you see a film. And if you see a grossly rotated film, it's better to get another one done rather than trying to report on this. And in children, chest is tubular in shape, and there is a prominent organ called thymus, which can be seen up to around 5 to 6 years of age, after which it involutes for all of us. So if there is something in the superior mediastinum which looks like a pneumonia, there is some opacification. Look twice before you report it as pneumonia. It might be just a normal thymus. So these are the differences in pediatric X-rays when we compare it to adult. Now, so we have an X-ray which has been taken and we have it in our hand. Let us see if it is an X-ray which can be reportable. So first of all, we need to know if it is P or AP. So if it's a portable film, it's an AP projection that we already know. We look at the penetration of the film. Is it well penetrated? Is the exposure good? So if it is an underexposed film, it would usually, the lung fields will be highly dark. You can see well exposed, well penetrated film where the lung margins can be seen till almost the periphery. It's usually seen in the middle and the medial 1/3 and a little bit in the periphery as well, the lateral 1/3 as well. But if it is an underexposed film, these lung shadows are going to look very, very dark. Like I'm sure in adults you have seen COPD or emphysematous chest X-rays, it would look like that without any margins. So then you know that if this is a underpenetrated film. So that won't be good for reporting anyway. And third, you will look at whether it is an inspiratory or an expiratory film. This is a film which is an inspiratory film where you can see the posterior lung border of the ribs. You can see around 6 to 8 ribs posterior border, which can be easily seen. So that means the lung is well inflated and you can report the lung parenchyma very well. Whereas if it's an expiratory film, you may be able to see only around 4 to 5 posterior ribs. So when this happens, the lung is actually pushed up. The diaphragm, here in this X-ray, the diaphragm is looking like this. In your expiratory film, the diaphragm will be, the domes will be pushed up like this. And so that X-ray again will not be good for reporting the lungs. So if it is very bad X-ray and you really need an X-ray for that child, go ahead and ask for a second one. But otherwise, if you can manage with this, then no need to. If you don't see any gross pneumothorax, things like that, then you can even manage with that. And finally, you look at the rotation. So rotation is looked at based on the position of the clavicles and the position of the trachea. Here you can see two clavicles which are equidistant from each other and symmetrical to each other. So this is the position of, this is how the clavicles are. So if one clavicle looks like this and the other looks like this, then you know that it is a X-ray where there has been a rotation, and that is why the clavicles are asymmetrical. And if the clavicles are symmetrical, but the trachea is still pushed to one side, then you know there is something in the mediastinum which is pushing the trachea. So you look at whether it's an AP or a PA view, you look at the penetration, you look at whether it's an inspiratory or an expiratory film, and it's a non-rotated film or minimally rotated so that you can still look at it. If you are okay with all of this, then we go ahead and report the next part of it. Now the next part is starting from this. So there is an order of reporting X-rays, which is good to know because then you don't miss out anything. So I'm sure radiologists also follow the similar order. So you start with the mediastinum. The mediastinum is the part which is between the two lungs. So you have this area, you know the surface anatomy on the left side and the right side. You know both sides you can look at it. And if there is anything abnormal in the mediastinum, then you come to the pleural outline. You can see the pleura, you can see the postophrenic angle and the cardiac phrenic angle on both sides. You can see, and you can see if there is any evidence of pneumothorax here. Third, you look at the hilar shadow. So hilum is this prominence which is seen in the middle of the mediastinum where you have the major vessels, the pulmonary arteries, the pulmonary veins, as well as the major divisions of the bronchi, the right bronchus and the left bronchus, which is dividing. So this is a normal hilum. You have seen some prominence here and some a little bit here. So this is a normal one, but this is highly prominent sometimes when you know there is something else happening in the hilum. Then you look at the trachea and the bronchial lucencies. Again, trachea coming down as the right and the left bronchi. So that also can be seen. We will look for any obstruction. We will look for any edema, intimal, the smoothness of the interior smooth intima can be also checked. If there is some edema that can be visible here, that is also very important. And finally, the lung parenchyma. So after all this, only the lung parenchyma comes. It's not like you jump and see the findings in the lung first. So you have the lung parenchyma on the right and the left. You look at that. The zones also, we'll discuss the zones in a bit. And finally, beyond the chest wall. So after the lungs, it doesn't stop here. You look at the ribs, you look at the soft tissue around it, whether there is any evidence of surgical emphysema. You look at any tubes which have been put, like ET tube, there might be an ICD tube, there may be a RICE tube. So all these things can be also looked for in this chest X-ray. So this is the order that we'll follow today as well. So we start with the mediastinal outline. So the mediastinum on the right side, we can see here, this is an adult X-ray, but the outline is exactly the same in children and adults. So you have the superior vena cava coming down, and after that it enters into the right atrium. So here the right margin is actually formed, but the right border of the hilum is formed only by the superior vena cava and the right atrium. There would be little bit of prominence here because of the right hilar contains the pulmonary arteries, the veins, as well as the bronchi divisions as well. What about in the left? You have the left, you have the aortic knuckle here, and after that the hilum forms a part of it. So the hilum, you have the left pulmonary arteries and the veins which will come here, and you have the bronchi and the divisions also. And after that comes the left atrial appendage or the left atrium, and then finally you have the left ventricle. So here on the right, it is only superior vena cava and the right atrium, whereas on the left you have four constituents. You have the aortic knuckle, the hilum, followed by the left atrial appendage, and followed by the left ventricle. So the four constituents of the left border. So based on this, if there is an abnormality here, say something which is prominent here, then you know what to think of. Say sometimes this becomes very prominent. So then you know the right atrium is prominent. And this is also important for surface anatomy for the central lines. So wherever you put a central line, usually if it's a jugular or a subclavian, you want the tip to rest between the superior vena cava and the right atrium. The junction between the SVC and the RA, that is where the tip should rest. And this is exactly what we usually follow. Around 2 centimeters below the sternal ankle will be that position that we usually look for. Another thing which we can see from the mediastinum is whether there is cardiomegaly or not. So in a normal PA projection, there is this calculation used for cardiothoracic ratio, where you can see the maximum diameter on the left and the right divided by the transthoracic diameter, and this is usually around 0.5. So if it is more than 0.55, that would be cardiomegaly, and this is only in a erect PA projection. When you have a pediatric X-ray which is taken with an AP projection or as a supine film, then this calculation will be erroneous and we do not usually follow it. And one more aspect to the mediastinum is, when you have a mediastinum, say suppose there is a prominence here, we do not know if it is, we have seen it only and from front to back. We have a prominence here. We actually do not know whether it is arising from the anterior, the middle, or the posterior part of the mediastinum. So for that, a simple lateral X-ray can help and can help us avoid a CT scan in these patients. So if you do a lateral X-ray, an angle, a line drawn at the sternal angle, anything above that is the superior mediastinum, and anything below that is the inferior mediastinum. And inferior mediastinum again is divided into three parts: the anterior, the middle, and the posterior mediastinum. Anterior is everything in front of the cardia, middle is along with the cardia, posterior is behind the cardiac shadow. Superior and anterior mediastinum, that is this part and this part, have the same contents normally. It would be usually the thymus, it could be the thyroid as well, it could be sometimes teratomas can come in this area, and finally some lymph nodes can also come in this area. So there are 4 T's to it to remember. One would be thyroid, second would be thymus, third would be teratoma, and fourth is a lymph node, which is massively enlarged lymph node in this site, is usually a lymphoma. So we call it a terrible lymphoma to remember. So TTTT can be as a mnemonic which we usually use to remember constituents of the superior and the anterior mediastinum. Middle mediastinum, again hilum comes here. So your hilar lymph nodes come here, and posterior mediastinum, anything originating from the vertebral area, the neurovascular bundle, etc., comes here. So for COVID purposes, it's usually not, we don't see lymphadenopathy in pediatric COVID. So if there is something, some mass which is coming up, you have to make sure that what is it? Is it a pneumonic map? Is it a medial pneumonia, or is it a lymph node? And if it's a lymph node, usually it warrants further evaluation. So this is an mediastinal outline which we have seen, the trachea which is dividing. You can see the hilum also on both sides, and see on the left side, sorry, on the right side, you can see there is a prominence. Now this prominence could be mistaken as a pneumonia, but if you can see this X-rays of a small baby, and in a small baby, this kind of mass, especially on the right side, can be a thymus as well. We have another X-ray which shows the thymus margin very clearly. And again, on the right side, it originates from the superior or the anterior mediastinum, it goes on to the right side. And in here, you can even see the very clear margin, which is called the sale sign. So this sale sign can be seen. So if for a new person to pediatrics, this can be reported as a consolidation. So whenever you see something very homogeneous in a small baby, come on the right side, on the upper lobe, then always look for the sale sign, and always it could be a thymus as well. Now after the mediastinum, we come to the hilum. Hilum I already showed you. These are the constituents. The right and the left hilum is seen. The right hilum is a little lower usually than the left. And hilum, the density of the hilum is usually equal on both sides. Hilar prominence is seen in a lot of infections because there will be inflammation of the bronchi. So the bronchi and the bronchioles can get inflamed, and even the vasculature can also, the vessel increased pulmonary flow can be seen. So because of all this, there can be prominence of the hilum which is seen. And this is described in a lot of infections, including COVID. We'll come to this description. So it's usually called perihilar streaking or perihilar prominence, etc. Now you come to the trachea and the bronchi. So you have the trachea, which is dividing into the bronchi. You can see the carina, which is the junction of both the bronchi. It is helpful to know multiple things. If it's a baby with respiratory distress, you need to know whether the trachea, especially if it's a stridor, you need to look for an upper airway obstruction. So you can see here, you can see the smooth borders of the trachea. There is hardly anything obstructing either from outside or from inside. If there is a narrowing of this air shadow, then you know there is some kind of obstruction which would require probably an ENT evaluation and the CT neck as well. Second, if the trachea is shifted to one side, say suppose you have a pneumothorax on this side, and it will push the trachea and the contents of the mediastinum to the opposite side, that also can be seen very clearly on an X-ray, and immediate action would be required in such a case. So these are simple things which you can look for in a chest X-ray, and you can act on immediately. And after this, we'll come to the lung parenchyma in detail. And beyond the chest wall, we already saw chest wall, the abdomen gas shadow in the gastric fundic gas bubble can be looked at. And whether it's a rice tube is there or not, that can be looked into. ICD tube, ribble outline, etc. can also be seen. Now coming to the main part, which is the lung parenchyma in case with pediatric COVID. So before you report a lung parenchyma per se, you need to know what are the abnormalities that what is the format of reporting a lung abnormality. We usually look at whether it is a lobar or a diffuse pneumonia. Lobar means it is bounded by the anatomical border. So it is a right upper lobe, middle lobe or lower lobe. Left if it would be upper or lower. Maybe it is bounded by one. So you can see the clear margin of the fissure which is very clean. It could be diffuse as well. In viral infections, usually it is involvement on both sides. So it would be described as either bronchopneumonia or interstitial pneumonia. It would be patchy, streaky, linear bands. These are terminologies which are very commonly used. It could be central or peripheral. So here again, central is the middle, the medial 1/3. The one which is completely medial would be the central part of the lungs. Then everything in the middle and the periphery 1/3, which will actually come as peripheral 1/3. So whenever you describe, it is good to know all these things because two people who describe an X-ray can describe it in a similar manner. It should not be like the resident reports it separately, faculty describes it completely differently. It should not be like that. Everybody should be aware of the ways of reporting a chest X-ray. And finally, you need to look at the zones of an X-ray. So in an adult X-ray, it is usually, I'll come to another, a larger, so in adult X-ray, it is usually reported as upper zone, which is the area above the second rib, the anterior margin of the second rib, which is what I am showing. Upper zone, middle is between second to fourth rib, and anything below the fourth rib is called the lower zone. Whereas in pediatric X-ray, usually the area itself is so small, so you can't really divide it into upper, mid, and lower, may not be feasible. So then another way is to draw a line at the hilum, and anything is above is called upper and below it is called lower. So that is again very simple way of describing the zonal involvement. So this is how you describe the lung parenchyma. So way back in when COVID started, this was one of the earliest papers that came out, which described the X-ray findings of pediatric COVID-19. This is from Spain, and they looked at around 44 patients. Many of those children were admitted because they had comorbidities. And they described two findings in pediatric COVID. One is called ground glass opacity. This I'm sure all of you have heard, because all of us would have had friends or relatives, somebody who's had COVID till now, and would have had an X-ray or a CT done where this report would have come. So what is ground glass opacity? Ground glass opacity is an area of diffuse haziness. So you can see on this film, you have A, section A. The A is when the disease is starting off, and you can see there is a diffuse haziness which is there in the left lower zone. And here there are no definite margins for this haziness. So that is also very clear. You can see there is no definite margins. And the third part of that ground glass haze opacification is that these lung margins, you can even make out through these ones also. You can see the lung margins clearly. So this is basically it's either infection or it is fluid, which is a haziness which is caused by that. But how is it different from a consolidation? See, this is a consolidation. By C, it has become a good consolidation. So C, you would report it like normally what we do. We reported it as a non-homogeneous opacity located in this area with an air bronchogram, which is seen very clear. You can see the air in the bronchus, and because there is dense collection around it, this air becomes very, very clearly visible. Whereas a ground glass opacity is a diffuse haze. Here again, you can see the margins of this consolidation are very clearly seen. Whereas here, there is no margin. Margin cannot be seen made out. So diffuse haze with no margins, where lung markings can be very clearly made out. And so this is basically a ground glass opacification. It was usually used to, it was there before COVID also. It was used for describing viral infections and even fungal infections in neutropenic patients. So that used to be CT, X-ray used to be used for, CT used to be used for that. But nowadays, the same finding has been described in X-rays as well. So this is the picture. So this is how it started off with, and the same patient has progressed. Now you can see it bilateral, and then here again it is progressed, and finally after some time it has cleared off. Now what are the other typical features of these ground glass opacities are? One, it is peripheral. It is originating in the periphery. It is not originating in the center of the lungs. So peripheral, and it may be bilateral or multifocal. So here you can see it's on both sides it is seen. It is peripheral. Central, relatively area is spared. So that is very classical of COVID infection. And bilateral. So multifocal, subpleural or peripheral GGOs, and bilateral GGOs. This is given classically described for ground glass opacities in COVID-19 infection. And this again to just understand the concept of a GGO and the consolidation. GGO is when the opacification has just started. So if you have vessels going through it or airway going through it, you can still see it is like frosted glass. I'm sure all of us would have tried to look through frosted glass. If the frosting is not very heavy, then you can see the other part very vaguely. You can see if somebody is moving or something is there. You can see. So that kind of way haziness is there here also. But by the time it becomes consolidation, all the markings get obliterated. But if there is an airway going through it, the airway will still have air in it, and that is how you get the air bronchogram. So this is a cartoon to describe that. The second finding they described in this paper was peribronchial cuffing. So what is peribronchial cuffing is this kind of prominence in the hilum. That is because the pulmonary, the bronchi divide into the bronchioles at this area. So you have this right main bronchus which is coming down. So whenever there is a viral infection, there would be inflammation of the bronchi and the bronchioles. And this inflammation, when you look at it from an end-on view, so this is the view when you are seeing like this, front to back. But if the bronchus is like this, you can see it from an end-on view. You can see air inside the bronchus, and the wall of the bronchus, because of the inflammation, is a little thickened, and that looks like a cuff around the bronchus. So this is the peribronchial cuffing, which has been described in a lot of viral infection. It is not specific for COVID-19. It can be seen in influenza. It can be seen in adenovirus, H1N1, lot of other infections as well. But it has been seen in more than 80% of pediatric COVID as well. So that has also been used as one of the criteria for diagnosis. And this is a pattern of reporting that has been there. You have typical, indeterminate, atypical, and negative. So that is how you report. Typical COVID-19 means what we just saw. You have bilateral, peripheral, multifocal GGOs, which are seen, GGO or consolidation. Bilateral, peripheral, multifocal or subpleural GGOs, which are seen. It could be GGO, it could be consolidation. This is very typical of COVID-19 pneumonia. What is indeterminate? Means it is seen in COVID-19, but it could be seen in other viral infections also. We're not very sure it is due to COVID-19 per se. So that would be unilateral GGO. It could be bilateral peribronchial thickening, again seen in a lot of other viral infections. So it is not very specific, but it is seen in COVID-19 as well. And it could be multifocal GGOs, which are not peripheral. It could be some are central, some are peripheral. That kind of distribution is also reported as indeterminate. And finally, atypical would be some finding in the X-ray, which would tell you, even if it's a COVID positive patient, you need to rule out another cause for it, like lymphadenopathy, like pleural effusion. So although pleural effusion is common in a lot of viral infections, it is not seen in COVID-19 person. So pleural effusion, lymphadenopathy, single consolidation, lobar consolidation, or miliary shadow, these kind of things, many a times, I'm sure many of you would have also seen that a child who comes with a COVID diagnosis, when you actually take the X-ray and evaluate further, there would be an associated tuberculosis or an associated bacterial pneumonia. So that kind of picture is very common, and these findings, these atypical findings, should warrant an evaluation for those. And finally, if none of these things are there, it is reported as negative. And this is from a consensus statement, which was published again in 2020 in cardiothoracic imaging by a group of international expert group of radiologists. So these are typical findings again. So you can see GGOs here, very clear, haziness, no margins, but lung markings are clear. So that kind of picture, bilaterally and peripherally more common than in the central. So this is a very typical COVID-19 pneumonia. But what about this? This is a unilateral finding. So this is unilateral is not typical. This kind of picture where it is, this again is not very typical of COVID-19. And this is a round pneumonia, again atypical of COVID-19 pneumonia. And these are again shadows. These are also looking like GGOs only, but they are central in position. So then again, it would be reported as indeterminate. So this picture, the more you see, we get to used to it. Then again, bilateral interstitial pattern. This is again, you can see peripheral involvement is more very typical of COVID-19 infection. So here again, you can see the same. And if you have unilateral, this was, I think they're trying to show the peribronchial cuffing and the peribronchial, the hilar thickening, which is seen. Again, hilar prominence, peribronchial cuffing, which can be clearly seen in this X-ray. Focal consolidation, not very typical. Perihilar streaking, seen very commonly, but not specific for COVID-19. Now, X-ray, like CTs, I'm sure all of you have heard of CORADs or CT-dependent scoring system for COVID-19. X-ray can also be used for COVID, but in most cases in pediatric, the severity would be defined by your clinical severity and not based on your X-ray severity. So just to highlight this point, I would like to share some pictures of our patients. So these are two children who came to us. You can see their saturation in room air, 85 and 65%. So these are severe COVID pneumonia infections. You can see the X-ray. So you can see again peripheral origin consolidation. Here also there is a consolidation more in the periphery. So bilateral consolidation, peripheral more than central. Here again there are consolidation as well as GGOs, again peripheral more than central. So this again is very typical. And both these children required HFNC and high flow oxygen, and they improved. What about these two children? These are again two more children presented with COVID-19 infection, but look at their saturation, 95% and 98% in room air. They both of them improved without any, not even oxygen supply. But you look at their X-rays, X-rays are as bad as the earlier ones. You have again peripheral involvement, which is seen, consolidation and GGOs are seen. And here again, some more other findings like some cysts and things like that are also seen. And these are also very bad X-rays, but they are not reflected in the saturation. So clinical management would still be based on what we heard till now. That is mild, moderate and severe would be based on your respiratory rate, workup breathing and saturation and not based on your X-ray. So that is what I wanted to say. Although there are severity scores which are available, but maybe that would be of benefit for a study where you are evaluating a drug, you're looking at radiological clearance, etc., not for clinical management. And other things. So after the lung parenchyma, so what is left is what all else can be seen. So one would be an ET tube. You can see the ET tube. You can see all the lines and the tubes. So ET tube is usually around 4 to 6 centimeters upwards of the carina. They have marked it for us. See, so you have the trachea and the carina, which is the division of the trachea into the two bronchi. And this ET tube, the tip of the ET tube should be around 4 to 6 centimeters above. As the child is younger, this distance would be lesser. And in a neonate, even 1 centimeter above the carina is fine. So if a tube is going on to the right side, then you need to pull it out. And usually you don't do like an X-ray to look at an ET tube position. But at times, if it's a ventilated patient, ventilation is not good. So maybe you do an X-ray and then you can even confirm an ET tube as well. This X-ray also has a Rice tube in position. Another thing what we look for is the central venous line. Like I said, even if it's a subclavian or a jugular or a PICC line, your tip should rest at the junction between the superior vena cava and the right atrium. So this is a good position. And here again, you can see an X-ray where a child, you can see the left arm, you can see the PICC line, which is coming up from the cubital fossa, it is coming up and the tip is resting here, exactly at the position that we mentioned, the junction between the superior vena cava and the right atrium. So that is a good place where it should be. Rice tube, this is a rotated film. Don't comment on a lung X-ray, lung film findings on that. But this X-ray can still be used to look at the Rice tube position. Again, tip of the Rice tube is basically a clinical decision based on how you put it, the calculation. And if you take an X-ray for some other purpose, you can look at a Rice tube. You don't need to do an X-ray for that. And this is a chest tube. You can see the position of the chest tube as well. You can also look for surgical emphysema if there is a chest tube in place because there would be some air leak around it. One important thing for which you do X-rays in pediatric COVID would be to look for complications of pediatric COVID. So what are the complications that you would expect in a lung film? Would be one, a secondary infection. I think the most important thing a child is you're treating for the patient, but fever is not responding. Or child has respiratory distress or workup breathing has increased, then you look for an additional complication like a bacterial pneumonia. You look for a pleural effusion or a pneumococele or fungal infections as well. So we'll see some of these pictures. Second, a ventilated child suddenly deteriorating or ventilated child suddenly air entry is not there on one side. So again, you are suspecting a barotrauma related to the ventilator or a ventilator associated pneumonia. Then again, you ask for an X-ray, a repeat X-ray. And third is a pulmonary artery thrombosis. So also very, very common in adults in pediatric COVID, will have pulmonary thrombosis and it's called pulmonary COVID associated coagulopathy. We generally don't see it as much in pediatrics. And even if you see, X-ray would not be a good measure for that. That is probably the only indication why you would ask for a CT chest in a pediatric COVID patient. So this is a picture. This is not a COVID patient, but this is a fungal infection patient in an immunocompromised state. So secondary fungal infections have been reported in COVID-19. How are they going to come to you? Here again, you can see a vague infection. This is the same child 3 days later. You can see a cyst which is forming, or cavity which is forming in this area. So the vague cavity here and there is a cavity here. I hope you can make it out. And this is the same picture of the child. So it came with a necrotic mass in the nose with respiratory distress. And this one grew aspergillus. In COVID, we've been reporting mucormycosis in similar patients. And this child has improved following amphotericin. That infection has cleared off. Similarly, ventilator-associated infections, pulmonary edema, embolism, barotrauma, all that can be looked for in an X-ray. Here you can see an X-ray where you can see the pneumothorax. How can we make it out? The lateral part, there is very, very clear air shadow. There are no lung markings. See, compared to the opposite side, you can see lung markings till the end, whereas here there are no lung markings at all. And you can see the lung margin, the lung is collapsed and the margin of the collapsed lung can be seen. So this is pneumothorax and requires urgent intervention. Here, the lung margins per se are normal, see, but what else can you make out? You can see free air. This is in the mediastinum, and this is surgical emphysema, which is there in the axilla. So there is again some air leak happening somewhere. You can see pneumomediastinum. And these kind of air leaks have been reported in COVID as well. So you can see surgical emphysema and pneumomediastinum in this picture. And finally, the most important question, when should we be asking for imaging? In pediatric COVID, the first X-ray would be for children who have moderate to severe COVID, that is tachypnea, work of breathing, and low saturation. Like in any other child with respiratory distress, you would ask for an X-ray. But after that, do you need to repeat an X-ray if the child is improving? Absolutely not. That is not at all required. If the saturation is picked up, work of breathing is reduced, child is comfortable, otherwise no need to repeat an X-ray. You may repeat an X-ray if complications come up, like child not improving, tachypnea worsening, air entry absent on one side. Those kind of things you would repeat an X-ray. What about CT scan? Definitely. There is risk of radiation, there is risk of difficulty in sedating, and you may have to transfer the child to another room or outside your hospital for a CT. That all becomes risky. So generally, we don't prefer CTs in children with COVID. Only reason would be to look for a thromboembolism if you're suspecting a pulmonary thromboembolism, a D-dimer which is going up, fever not settling down, hypoxia not settling down, then you would look for it. Because on an X-ray, you cannot really make it out. The only clue you can get from an X-ray in a pulmonary embolism is a prominent right atrium. So that right hilum thing which will become prominent because the right RA dilatation can be seen. So to conclude, when do you order an X-ray? Any moderate to severe respiratory illness you will order, and when complications are suspected, you would order. What do you look for in the chest X-ray? You look for lung parenchymal findings. Typical would be bilateral, multifocal, peripheral GGOs. Indeterminate and atypical also should be looked for. Complications can be looked for like pneumothorax, pneumomediastinum, fungal infections, etc. And lines and tubes should be looked for. Is there any need to repeat an X-ray? There is no need to repeat unless you suspect any complications. So that's my last slide. And I think we have fulfilled all the objectives of today's class. We've looked at X-ray abnormalities related to COVID. We have looked at the judicious X-ray use of X-ray. So no more sequential X-rays need not be ordered if the child is improving. We also identified tubes and lines in the ICU setting and its correct position. And we also are sensitized to complications related to mechanical ventilation. Finally, I would like to thank all the contributors of these slides, and I'll be happy to take any questions.
Thank you, Dr. Neeta, for explaining everything so beautifully. And there is only one question for you. What will be the cardiothoracic ratio of a COVID child?
So I already said that COVID, we don't expect cardiomegaly in COVID as such, but if it is a MISC and you are suspecting cardiac function, your LV ejection fraction has come down because of myocarditis or because of MISC, then echo is a better modality to rule it out. So echo will tell you there is dilated cardia and what is the ejection fraction. These are the two situations where you see cardiomegaly in COVID scenario.
Yes. And I think there is no more question. Let me see once. How pneumothorax can develop in COVID?
So in adult COVID, see, once the lung improves, there's a lot of fibrosis that is left behind. So this fibrotic lung can develop something similar to pneumatoceles can be seen, and this can actually go on to have pneumothorax. So we've seen it in children, in patients with COVID. In pediatric, that kind of severity of disease is not very common. So, but if it happens, then the mechanism would be similar. Basically, lung fibrosis followed by pneumothorax. So it can rupture either ways. It can rupture towards the pleura side, or it can rupture onto the mediastinum side also. So pneumomediastinum can also be seen in COVID. And second is if you are bagged with a barotrauma secondary to bagging or secondary to ventilation, if the pressures are high, those things can also lead to pneumothorax.
Yes. And one more question, can we take 0.6 as ratio in infant's X-ray? This is about the CT ratio.
Yeah, that's the classical teaching. But then again, that X-ray should be properly taken for that purpose. So supine X-ray in an infant will not be a good modality to calculate CT ratio.
Okay, so there is no more question for you. So thank you, Dr. Neeta. And with this, we come to the end of today's session. And you must be happy that we have finished before time. And there is one query regarding that, is there any module or literature of this training available? So I just want to tell you that all the participants at the completion of this training program will get a link to all the PPTs. So thank you all. And tomorrow again, we will start at 12 noon. So thank you, everyone.